After putting on gown, gloves, and face protection, place an absorbent pad across the patient's chest and provide an emesis basin. Position him sitting upright in the bed. Place his head in the sniffing position with the neck slightly flexed and the head slightly extended. Assess the patency of the nasal cavities by instructing the patient to inhale through each nostril individually and asking him which side provides better airflow. Look in the nasal passages with an otoscope to identify septal deviation or other impediments to tube insertion. Use these observations to choose the appropriate side for tube insertion. Next, apply a topical vasoconstrictor such as oxymetazoline or phenylephrine to shrink the nasal mucosa. This opens the nasal passage, which reduces risk of bleeding and makes tube insertion easier. Because nasogastric intubation is painful, it's important to obtain good anesthesia by careful application of a topical anesthetic to the nose and throat. There are several options. 4% lidocaine can be applied with an atomizer. 3 milliliters for the oropharynx and 1.5 milliliters for the nasopharynx should be adequate. Alternatively, 4 milliliters of 4% lidocaine can be given by nebulizer. Other options include topical benzocaine spray for the throat and viscous lidocaine for the nose. Next, prepare the nasogastric tube. To keep from losing the suction adapter supplied with the tube, remove it from the nasogastric tube and insert it into the suction tubing. Place the suction tubing behind the patient's pillow so it is within easy reach. The proper depth of insertion is roughly the distance from the xiphoid process to the ear and then to the nares. Note which of the black marks inscribed on the tube corresponds to the appropriate depth. You'll insert the tube to that mark. Lubricate the tip of the nasogastric tube with either viscous lidocaine or surgical lubricant. Make sure the patient is sitting upright. It may help to place your other hand behind the patient's head to prevent him from suddenly pulling away. Gently begin inserting the tube. Make sure the tube is parallel to the floor of the nasal cavity. It's a common mistake to direct the tube upwards, where its passage will be blocked by the middle turbinate. Note that when the tube is directed correctly along the nasal floor, it easily passes underneath the inferior turbinate and onto the posterior nasopharynx. You'll feel resistance when the tube reaches the posterior wall of the nasopharynx. Stop here and allow the patient to rest before you push the tube around the corner into the pharynx. This part of tube insertion may be quite uncomfortable despite adequate anesthesia. Now advance the tube with steady pressure until it turns the corner into the posterior pharynx, which is indicated by a decrease in resistance. The patient may begin gagging. Now you are ready to advance the tube into the esophagus. This fluoroscopic view shows the tube in proper position in the back of the throat, ready to advance. Have an assistant hold a cup of water with a straw for the patient. Tell the patient to begin to swallow the water and carefully coordinate advancement of the tube with swallowing so that the patient in effect swallows the tube. Rapidly insert the tube to the predetermined depth. Correct timing is essential. If the tube is advanced during inspiration, it will likely enter the trachea. But during swallowing, the epiglottis covers the laryngeal opening so that the tube is more likely to enter the esophagus. Assess proper tube placement by asking the patient to speak. If the patient cannot speak or has a hoarse voice, the tube is probably in the trachea and should be removed immediately. Next, inject about 30 milliliters of air into the tube with a catheter-tipped syringe while listening over the epigastrium. Hearing a gurgling sound suggests the tube is properly placed in the stomach. Then use the syringe to attempt to aspirate gastric contents. Obtaining gastric contents confirms gastric placement, but often no gastric contents will be obtained even though the tube is properly in the stomach. A chest X-ray can definitively confirm tube placement. If the nasogastric tube is clearly below the diaphragm, it is in the proper position. A chest X-ray is not mandatory because the other methods of confirming placement are accurate enough for most situations. However, if any substance is to be given through the tube, for example radiographic contrast media or liquid feedings, a chest X-ray is highly recommended to ensure the liquid will not mistakenly be put into the lungs. After proper placement has been confirmed, attach the nasogastric tube to the suction tubing. Adjust the vacuum force to low or medium and set the control dial to the intermittent position. Finally, secure the tube to the patient's nose. First, attach a piece of adhesive tape that is ripped vertically for 1/2 of its length to the patient's nose. Then wrap the tails of the tape in opposite directions around the tube.